Welcome to the Deep Dive, where we unpack complex medical topics for your clinical practice.
Ready to be here.
Today we're delving into distal clavicle osteolysis DCO. It often gets called weightlifter's shoulder.
That's right, although that name can be a bit limiting, actually.
Exactly. It affects a wider range of active people than you might think, and it's easily missed. So this deep dive is, well, pretty crucial for clinicians.
Absolutely.
I'm joined by Prof. Mo Imam, whose orthopedic expertise is invaluable for synthesizing this kind of complex information.
Thank you. Yes, DCO, it certainly has its nuances. I'm keen to explore the clinical essentials for our audience today.
Great. So let's start unpacking it. For clinicians perhaps less familiar, what exactly is distal clavicle osteolysis? Could you set the scene?
Certainly. DCO is fundamentally a painful musculoskeletal condition. It affects the acromioclavicular joint, the AC joint.
Where the collarbone meets the shoulder blade.
Precisely. Where the distal end of the clavicle meets the acromion. And the key feature, the hallmark, is the deterioration and resorption of that very end of the clavicle.
Okay.
And we generally think of two main types. There's atraumatic DCO,
Yeah.
which comes from repetitive stress.
The weightlifting connection?
Yes, high-intensity weightlifting,
Yeah.
especially bench pressing, but also overheads, sports, volleyball, tennis, swimming, basketball, that kind of thing. And then there's traumatic DCO that typically follows an acute injury, often an AC joint separation.
That's fascinating. Now, that weightlifter's shoulder nickname, who are we actually seeing present with DCO in clinic? Is it just young male lifters?
Well, that's a really good point.
Hmm.
Epidemiologically, yes, we do see it predominantly in young athletes, weightlifters, often males in their 20s.
Okay.
But importantly, we're identifying it more and more in female athletes engaging in similar high-intensity activities.
So the picture is broader.
Definitely.
Yeah.
Just to give some figures, after an AC joint separation, the incidence of developing DCO is somewhere between, say, 6 and 12%.
Not insignificant.
Not at all. And if you look at adults presenting with general shoulder pain, there's about a 5% prevalence of DCO, and that's strongly linked to high-intensity bench pressing. But the crucial thing, physiologically, is that it can occur at any age. So you need that high index of suspicion across the board.
Right. Keep an open mind regardless of the patient's profile. So let's look into the why. What's happening at the cellular level here? What causes this deterioration, and how does it manifest for the patient?
Okay, so the most widely accepted thinking on the pathophysiology revolves around repetitive microtrauma.
Tiny injuries accumulating.
Exactly.
Yeah.
Leading to microfractures in the subchondral bone, that's the bone just beneath the cartilage at the distal end of the clavicle.
Right.
Now, the body tries to repair these, of course,
Okay.
but the problem in DCO is that the rate of bone resorption, the breakdown, actually outpaces the repair process.
An imbalance.
A critical imbalance, yes.
Yeah.
And this fuels chronic inflammation. You see increased activity from both osteoclasts, the cells that break down bone, and osteoblasts, the cells that build bone. It's a chaotic process.
And sometimes more complex.
In some cases, yes. There can even be synovial invasion into that subchondral bone, making it, well, a more aggressive picture.
And clinically, what does the patient report?
Typically, it's a rather vague anterior shoulder pain, often described as a dull ache.
Not sharply localized initially.
Often not. It might radiate perhaps towards the trapezius muscle or the deltoid region.
Okay.
The real giveaway, though, is the exacerbation with specific activities. Bench presses, push-ups, any overhead movements, bringing the arm across the body, horizontal adduction.
Sleeping on that side.
Yes, even sleeping on the affected side can be quite painful for them. And a key diagnostic clue is the cyclical nature you mentioned earlier.
Better with rest, worse with activity.
Spot on. It improves with rest, but as soon as they resume those aggravating activities, the pain comes right back.
Just on examination.
You'll typically find point tenderness right over the AC joint itself, and the cross-body adduction test, bringing the arm across the chest that will usually reproduce their pain.
What about strength?
Interestingly, overall shoulder strength is often preserved.
Yeah.
However, patients might show some pain inhibition during specific resisted tests. They just can't push hard because of the pain.
That cyclical pattern and specific activity pain really do sound like key flags. Given these often subtle symptoms and the fact shoulder pain can stem from so many things, how do we nail the diagnosis? How do we differentiate DCO?
It absolutely starts with a meticulous history. Really listening to the patient, understanding the pain location, the aggravating factors, that cyclical nature, and then a thorough physical examination.
Okay.
Then we move to imaging. X-rays are usually the first line.
Standard shoulder views.
Well, standard views might show something, but the findings, loss of subchondral bone, maybe some cystic changes, AC joint widening, they can be very subtle,
So easily missed.
very easily missed. In fact, standard X-rays probably only pick up clear DCO findings about half the time. So meticulous examination of the films is needed, and specific views can help. The Zonka view, for instance, which has a 15-degree upward tilt, can sometimes show the distal clavicle changes more clearly.
What if the X-rays are inconclusive?
The MRI is much more sensitive, particularly for early changes. You show things like bone marrow edema swelling within the bone, which indicates that early stress reaction.
And other things.
Yes, cortical irregularity,
Oh.
any soft tissue swelling around the joint. MRI gives a much better picture of the early inflammatory process.
Are there other imaging options?
A bone scan or scintigraphy can be useful. It detects increased metabolic activity, so it might show increased uptake over the distal clavicle early on, sometimes even before X-ray changes are visible.
Okay.
And ultrasound is emerging too. It's cost-effective, allows real-time dynamic assessment, which can be quite helpful.
What about injections?
Ah, yes. CT-guided injections into the AC joint. They have a dual role, really, diagnostic and therapeutic.
How so?
Well, if injecting local anesthetic and perhaps some steroid into the AC joint provides significant pain relief, even temporarily, it strongly suggests the AC joint is the primary pain generator. It helps confirm the diagnosis.
That makes sense. And the differential diagnosis is crucial here, isn't it?
Absolutely critical. DCO symptoms can easily mimic other common shoulder issues.
Such as?
AC joint arthritis, obviously.
Yeah.
Subacromial bursitis, SLAP tears, even a chronic AC joint sprain.
And non-musculoskeletal causes.
Yes. Though less common, you have to consider things like hyperparathyroidism or rheumatoid arthritis, which can affect bone, and always rule out referred pain, especially from the cervical spine. A thorough neurological exam is essential.
So a comprehensive approach is needed to avoid misdiagnosis. Once DCO is confirmed, what's the management pathway? What does that initial conservative care look like?
The primary goal is always conservative management first. Surgery is really reserved for failures of non-operative care.
And the cornerstone is?
Activity modification. This is non-negotiable initially. Strict rest from those provocative movements, flexion, abduction, internal rotation, that horizontal adduction we talked about.
Giving the bone a break.
Precisely. Allowing for physiological bone healing. Patient education here is paramount. They need to understand why they must avoid those painful ranges. Compliance is key.
And managing the symptoms.
Alongside rest, yes. We use NSAIDs, non-steroidal anti-inflammatories, to manage pain and inflammation. And corticosteroid injections into the AC joint can be very helpful for symptomatic relief, breaking that pain cycle.
Right. So once the initial pain and inflammation settle, how do we transition effectively into rehabilitation? We have that really interesting case you mentioned, the 24-year-old female hockey player who did very well conservatively. Can you walk us through the principles of her rehab?
Absolutely. Her case is a great illustration of a structured multimodal approach. Once her acute symptoms settled with rest and initial management, the rehab began.
It wasn't just exercises, though.
No, not at all. It included manual therapy, hands-on work, soft tissue therapy for the surrounding muscles like pec minor, rhomboids, trapezius, the rotator cuff, and also spinal manipulative therapy for any restricted segments in her neck and upper back.
Addressing the whole kinetic chain.
Exactly. Because restrictions there can definitely influence shoulder mechanics and load the AC joint. Specific stretching was also key, particularly for her pectoralis minor, as she had that slightly anteriorly rolled shoulder posture.
Okay, and the exercise program itself.
It was progressive, broken down into 3 phases. The aim was to systematically improve her scapular control, how the shoulder blade moves, and her glenohumeral range of motion.
Phase 1.
Phase 1 focused on foundational stability, mainly with movements below the horizontal plane. Things like resistive band rotations for the rotator cuff, but with the shoulder down at her side, 0 degrees flexion. Also, wall or table push-up plus exercises, which are great for basic scapular protraction control.
And breathing, you mentioned that.
Yes, crucially, diaphragmatic breathing was integrated right from the start. Strengthening the core, stabilizing the spine, it provides that solid base needed for efficient load transfer up to the shoulder. You can't neglect the core.
Makes sense. Phase 2.
Phase 2 progressed to strengthening above the horizontal. So similar resistive band rotations, but now with the shoulder abducted to 90 degrees, horizontal push-up plus, and introducing exercises like scapular clocks.
Scapular clocks.
Yes, where the patient tries to move their scapula in controlled circles, like tracing a clock face against a wall, perhaps, It really works on dynamic scapular stability and control through range.
And phase 3?
Phase 3 moved into closed kinetic chain exercises, things like scapular hangs from a bar.
That sounds demanding.
It is, but it's excellent for improving grip strength, which actually correlates with shoulder rotation strength and for overall shoulder girdle stability. Also, exercises like low oblique sits, focusing on isometric scapular depression and core stability, still incorporating that diaphragmatic breathing.
It sounds incredibly thorough.
It was designed to restore the balance and efficiency of the entire shoulder complex, not just the AC joint in isolation.
And the outcome for her?
Remarkable, actually. Complete resolution of her symptoms. She regained full, pain-free range of motion and was able to return fully to playing hockey at her previous level within about a year.
A fantastic result, really demonstrating what targeted conservative care can achieve.
It really does highlight the efficacy of that detailed, multimodal approach.
But inevitably, conservative management doesn't work for everyone. What happens then, especially for, say, a high-level athlete or someone whose job requires those provocative movements they just can't avoid?
That's when surgical intervention becomes a consideration. But again, it's reserved for those who've genuinely failed a comprehensive conservative program or whose lifestyle or work makes activity modification impossible long-term.
And the main procedure?
The standard surgical option is a distal clavicle excision, often called the Mumford procedure.
Excision means removing bone.
Yes, removing the very distal end of the clavicle. But, and this is a critical technical point, only a small amount should be resected. We're talking 0.5 to 1 centimeter, or an absolute maximum of about 8 millimeters.
Why so specific?
Because if you take too much bone, you risk causing iatrogenic AC joint instability. You disrupt the supporting ligaments too much, leading to a different set of problems. Precision is key.
Are there different ways to perform this excision, open versus keyhole?
Yes, it can be done via an open incision or arthroscopically. The open approach gives direct visualization, which can be good if there are large osteophytes, bone spurs to remove. But it generally means a longer recovery, perhaps 5 to 12 weeks, and involves disrupting the deltoid trapezial fascia.
And an arthroscopic?
Arthroscopic techniques involve less tissue dissection, so recovery is often quicker. There are actually two main ways to do it arthroscopically. There's a direct or superior approach, viewing from above the joint. This avoids going into the subacromial space. Some studies suggest this might allow a faster return to sport, maybe around 21 days on average in one comparison.
And the other way?
The other is the indirect or subacromial approach. You work from underneath the AC joint, within the subacromial space. This approach tends to preserve the superior AC joint ligaments better. Both have good outcomes when done correctly.
Are there potential complications with surgery?
As with any surgery, yes. The main ones specifically related to this procedure are that horizontal instability we mentioned if too much bone is removed, and also heterotopic bone formation where new bone grows back, sometimes excessively.
Is that common?
It's more commonly noted in certain patient groups, particularly smokers or those with chronic pulmonary disease.
Right, important risk factors. So that precision in resection is vital. Looking overall then, what's the prognosis for patients with DCO? And crucially, what practical advice can we give for prevention?
Generally, the prognosis for DCO is excellent. As I mentioned, conservative therapy has a very high success rate. That 93% figure from one study is quite representative. Most patients do well without surgery.
That's encouraging. And prevention.
Prevention really comes back to activity modification and technique. For weightlifters, simple adjustments can make a difference.
Like what?
Narrowing the hand grip on the barbell, keeping it less than 1.5 times the width between their acromion processes, and modifying the bench press descent, stopping maybe 4 to 6 centimeters above the chest rather than touching the bar right down.
Reducing that end range stress.
Exactly. And more broadly, emphasizing proper form in all sports and activities is vital. Distributing load evenly, reducing unnecessary stress on the AC joint.
What else?
Balanced training programs are important. Avoid overemphasizing certain muscle groups, like the chest press muscles, without balancing with back and rotator cuff work. And gradual progression, don't suddenly ramp up intensity or volume. Allow the body to adapt.
General health plays a part too.
Absolutely. Avoiding smoking is beneficial for bone health generally. Avoiding overtraining, incorporating regular stretching and strengthening. It's all part of the picture.
And the role of the wider healthcare team.
Crucial. A multidisciplinary approach is ideal. Athletic trainers, strength coaches, physios, sports medicine doctors, orthopedic surgeons. Everyone has a role in early identification, patient education, guiding rehabilitation, and implementing these preventative strategies. It's about proactive care.
This has been incredibly insightful. So just to summarize for everyone listening, DCO, often subtle, needs a high index of suspicion for diagnosis.
Definitely.
Conservative management is the first line, built on rest, activity modification, and crucially, a detailed progressive rehab plan addressing the whole kinetic chain.
Spot on.
Surgery, usually distal clavicle excision, is reserved for failures, requiring precise execution to avoid instability. And patient education on technique and load management is key for both treatment and prevention.
Perfectly summarized. And if we think about the bigger picture here, recognizing those subtle signs of DCO early, implementing that tailored progressive rehab, it can genuinely make a profound difference to an active patient's long-term function and musculoskeletal health, often avoiding surgery altogether.
A really powerful final thought. Thank you so much for sharing your expertise today. It's been incredibly valuable.
My pleasure entirely.
And if you, our listeners, found this deep dive helpful, please do take a moment to rate the show and share it with colleagues who might benefit. Thank you for joining us on the deep dive. We'll be back next time to explore another critical topic.